edges. Either you have small fistula or large fistula, and you reconstruct them after 6 months of healing. Also, you can have residual corti. Why corti? Incomplete resection. You don't do your job properly. Recurrent fibrosis, inelastic urethra, intrinsic corporal defect, or short ventral skin. Also, you can get stricture fistula or a combination of these different complications. Or you can get a diverticulum, especially in the duct era. There was an era a few years ago, everybody was doing a duct procedure. I personally don't do it anymore. And at this era, you used to get lots of diverticulum. This is a huge diverticulum, post-hypospadias diverticulum from a duct procedure. The last thing is complete disruption. You lose everything. You come again, and by complete destruction means there is deficient skin, you get curvature, and this is an example, everything is lost, a scarred urethra, you don't have skin, and you have a problem. And the only solution is the multi-stage procedure. You come again and put a buccal mucosa and do it in multiple stages. At last, hypospadias is not a frequent surgical procedure. Either you do rates so that you face problems and have confidence. It's not a procedure where you just do it once a year or once in your life. So, and the best chance is the first chance. The first surgeon who puts his hand on the surgery is the best chance for the patient. So please be careful with hypospadias. Thank you very much.
Questions are allowed. If anyone has a question, it's open. I just want to remind Dr. Ibrahim, I think you forgot to mention the timing of the repair. When we start repairing the hypospadias, the age. Did you mention?
Well, I mean, the timing of hypospadias starts from after the age of 6 months. And the best period before they go to school or go to the nursery. Classically from 6 to 12 months. But in Egypt, before school, before they go to the nursery, minimum 6 months for the anesthesia problem, and before they go to the nursery for the psychological impact on the children.
One of the problems, I think, when we treat hypospadias is that hypospadias is kind of a spectrum of disease. There's the minors and they're more severe. And as pediatric urologists, we haven't really standardized the way we report on outcomes. And basically, we're comparing apples with oranges. And I think one of the ways to do that is maybe the scoring systems that are coming out right now with hypospadias, like the GMS system talks about the glans, the meatus, the shaft, and score them. And hopefully, by doing so, we can actually compare results adequately. The second thing I think is important is the issue of your first repair is your best repair. And the AUA this year, there was a couple of reports from Snodgrass, and when you have one complication and you do a redo first time, your risk of having complication doubles, and if you do it the second time, it triples and quadruples. So your first repair is probably the most important repair, and you have to be careful to make it really successful. The other issue is also the glans width is important. So glans under 13 millimeters, your complication rates are much higher. If urethral plate is under 4 millimeters, and that's why the inlay flap, right now I do inlay, I do a lot of inlays if the urethral plate is less than 4 millimeters, just putting a buccal mucosal graft or an interproputional graft when I incise the urethral plate.
Yes.
Yes, Dr. Salim.
Thank you, Dr. Ibrahim.
Question?
Thank you, Dr. Ibrahim, for a very nice presentation. As usual, you are our professor. I want to ask about the megameatus intact previous deformity, which is MIP, which represents about 5% of hypospadias. The plate is very wide and deep, but the plate is very thin. Which operation you prefer to do in such condition? mega meatus.
Well, for me, for the mega meatus and intact prepuce, you get down the skin, you find a very thin urethra, you do spongioplasty, and you do some sort of a tertiary. If you have a very wide meatus, if it's the meatus is not, which affects the voiding, you just leave it. But if it's a wide meatus, I recommend doing tertiary plate. But for the corpus spongiosum, you be careful, drop the skin down, and do spongioplasty. I don't know what's your opinion.
There is specific operation suitable for such.
Sorry?
Is there a specific operation suitable for such deformity, which is mega meatus and intact prepuce? Tape operation is preferred, or tertiary plate without second layer?
Many other parameters.
Yes.
That should be associated with the mega meatus, not only the mega meatus, the configuration of the glands, the
Intact prepuce mega meatus.
size of the penis,
Yes.
the degree of curvature. That will define your
I think-
decision. Not
Yeah.
only just
With the intact meatus, the important thing is when you're doing your gland slap, because the urethra is really wide, you've got to go lateral because you can easily get into the urethral plate by doing your gland slap. That's probably the most important part of your operation. And then as was said, it's spongioplasty, so really closing it in a couple of layers and putting a darto slap on top is really important.
Yes. Another question, Dr. Ibrahim. If we have glandular hypospadias with no cortea, without meatal stenosis, we can leave this patient without any surgery?
I personally do dorsal slit myself. If you have a meatus stenosis in the glandular.
No stenosis, no cortea, and glandular hypospadias, we can leave the patient alone without any operation?
If the patient doesn't have any psychological problem, leave him alone, because he will be much better if you leave him alone. Because if you have complication, you will go to lots of surgery. I personally, unless the patient asks for the surgery, I don't do the surgery.
unless you will go to a competition about
Yes. But usually, I mean, in these patients, they have to ask for the surgery. Otherwise, they will run after it. Because sometimes, if you have a complication, they will be worse. But if he comes and asks and said, well, I have a psychological problem, his mom is not happy, you'll try to do something. I don't know what's the states.
This is quite a huge issue in the United States right now. There are some advocates that actually tell us that we should not touch hypospadias. It's actually sexual abuse by doing that, and even recommend for the proximal ones to actually not do anything at all. I think, and I disagree with that. But I think for the distal ones, it's really important. What are you achieving by doing a hypospace, a glandular hypospace? And the kid will have normal voiding, normal erections. They'll be able to have children
There's
with
no
no
any
problem.
problem.
There's no reason to operate on them.
Thank you.
Okay, we are our next presentation by Professor Dr. Muhammad Isa.